Hello and welcome back to Fireside Chats about outcome measures. In this segment, I'm going to sort of wrap up the issues or the benefits of the outcome measure by talking about its role in post protective separation in relapse prevention. Sort of set the stage about what the outcome measures do. They monitor treatment progress, and we would want to see treatment progress in about significant progress in about 6 weeks, and would hopefully get a pretty full resolution of all the symptoms by about 12 weeks. So for the parent-child relationship rating scale, the outcome measure I'm recommending, it's a 1 to 7 rating by the targeted parent each day, emailed to the family therapist on 3 items: affection, cooperation, social involvement. And we're looking for 3, 4, and 5s, so normal range. And that would be the criteria that I would begin to use for ending the protective separation. So what I would look for is if I had 2 weeks of normal range ratings from the child, then I'm comfortable that the child's normal range healthy development has been recovered, because these ratings are coming from the targeted parent, but they're being verified in therapy by the therapist, so they're being monitored, the things. And so if I'm getting normal range ratings from the targeted parent, then that's good. That the child has done what I've been asking the child to do, is rebond to the parent. Just be normal. I don't need you to be 6 and 7s. Great if it happens occasionally, but just be normal with your normal range parent. Now, the protective separation period is very important for child abuse, particularly this child abuse, because we have psychological control of the child. So we have a parent here who's twisting up the child and psychologically controlling the child to and creating an alliance where that child is loyal to the pathological parent by rejecting the other parent. And if we then go in with our therapy without a protective separation and try to restore that healthy attachment bond, the pathological abusive parent is going to try to keep the child twisted up, and they're going to be turning the screws even harder on the child for that loyalty and be sure you reject that other parent while we're trying to fix the child. We're going to rip the child apart. So the better my therapy is at restoring the bond, the stronger the pathological parent's going to increase their pressure, the more the child is going to get ripped apart. So in order to do therapy, we need a little space. We need a bubble around the child where we can get that child to bond into that parent and to cooperate with us without the continual distorting influence of the narcissistic, borderline, dark personality parent. Once we get that child back, though, then we need to start thinking about restoring within the family. In the absence of child abuse, we don't restrict parents' time and involvement with the child. If the child's symptoms are normal range, the child abuse is in remission. It's in remission because the child's not having any contact with the abusive parent. Okay, I understand that, but it's still in remission. So we need to start moving towards a restoration with um, the pathological parent, the problematic parent. And so I would kind of I would feel comfortable with that. So I would anticipate hopefully significant changes by 6 weeks. So maybe the child's, let's say, is in normal range by 6 weeks, 3, 4, 5s on those 3 items. Then set week 7, week 8, if they've given me, a solid couple of weeks with this, I could begin to move into restoration with the abusive parent at a week 8. But typically, week 6 for the rest of these therapists may not be realistic, or the severity of things. So by week 12, though, I would anticipate therapy would have the child back in the normal range. If it doesn't, we need to relook at our diagnosis. We need to relook at our treatment plan at 6 weeks points. If we're not seeing progress at 6 weeks, we need to relook at things and see what we're doing. Have we accurately diagnosed everything? Are there barriers to treatment? What else is going on? Do we need to add interventions somehow or do something at 6 weeks? For attachment pathology, I would like, now this is my expertise. I'm an attachment guy and I've worked child abuse and stuff. I would want a resolution of this severity of attachment pathology within 12 weeks, no longer than 6 months. I don't want this pathology going past 6 months. This is too devastating to the attachment networks. Childhood is once, childhood is fleeting, childhood is supposed to get certain experiences in childhood, and we want to get this kind of done and resolved. And I can cite to Dorsey Pruder and their High Road workshop where it covers it in 4 days. So if the mental health people can't do it in 12 weeks, we need to be thinking about, we need to be talking to Dorsey, but we need to be thinking about things. She uses a different approach than psychotherapy, though, because that's why psychotherapy can't do it in 4 days. That we don't have a 4-day intensive psychotherapy thing that can fix it. No, that's not within our models of change. Dorsey's doing something different. Family Bridges kind of doing something different about how they approach change. And that's why they can get the recovery in that period of time. But what that shows is how easy it is to get the recovery. The reason is the authentic child is still there. The problem is the child is misattributing their grief response. So let me get rid of this for a second. They're misattributing their grief response. So when the divorce happens, the child feels grief over loss. The pathological parent takes that initial grief and twists it into blame and hostility towards the other parent. And so they twist it into anger. And then the moment that child breaches from the targeted parent, a huge grief response hits because that's what happens on breached attachment bonds. So now the child is dealing with this huge sadness, this huge grief. It hurts, but they don't know why it hurts. They know it has something to do with that parent, but and they got the distorting influence of the pathological parent saying it's because they're abusing you and treating you badly. And the kid says, I guess that's true because I'm hurting. I am authentically hurting. And but what happens in therapy, what happens in the high road, is once the child rebonds to that parent, the context is set up, and the child relaxes and rebond. That grief response just drops. It just disappears because now the attachment system is back active and rebonded. There's no grief response. It goes, oh, was that it? Was that what the problem was causing? It was because I wasn't bonded. Okay, I get it now. And so once we get to that point, then and that we can use that for a little bit more resilience. But once we end the protective separation, that psychological abuse is going to come back. That narcissistic borderline dark personality needs that child to be pathological. Needs that child to be pathological. And so there's going to be a lot of pressure upped on the child again. One of the ways we can help the child cope with that pressure, there's several ways, but one of the ways we can help the child cope with that pressure is tell the child that we're going to start restoring. You've done great. This is exactly what we're looking for. Your normal range, everything's going good. And so now we can start to restore into a normal range family. But we need you to just stay normal. Just be normal, just like you're doing now. Because if you drop back to ones and twos, we're going to say, attribute that to like your mom's problematic parenting. We're going to say it's your mom again doing this, and because your dad's normal dad. And so we're going to be back in this situation where we're reducing your mom's time with you. And we know you don't want that. Mom doesn't want, nobody wants that. So we just need you to stay normal with your dad here, and everything's going to be fine. The other thing this does, though, it gives us the ability to monitor the child abuse with the pathological parent and gives the child a way to tell us that the abuse has resumed. If the child goes back to be with that pathological parent, but stays 3, 4, 5s on the rating scale, then the child is communicating to us that no matter what's happening over there, the child's handling him because they're staying normal range. Okay, good, you're doing it. All right, so we develop skills, we do stuff. But if it gets overwhelming for them, then they just collapse into ones and twos. They don't have to come and tell us and rat out their loyalty to the pathological parent. They just have to cooperate with the pathological parent, collapse to ones and twos. That'll signal us that child abuse is resumed, and then we'll separate the child again. That's why that Excel file becomes really important, because we got it before, we got some ratings before the protective separation, ones and twos. We protectively separate the child and we see the recovery back to 3, 4, 5s. Then we're good. Everything's 3, 4, 5. We start to reintroduce the pathological parent again. Boom, it drops back to ones and twos. You go back into the court and say, look at this, Your Honor. It was clearly the reintroduction of the pathological parent. That's your AB kind of design. It's clearly the reintroduction of the pathological parent. The abuse is resumed. We need another protective separation. Now, what that does is it changes how the child's symptoms confer power within the family. Currently, the child rejecting the targeted parent, the child's symptoms, attachment pathology symptoms, give power to the pathological parent to manipulate the court's decisions on child custody and to inflict spousal abuse on the ex-spouse for having the temerity of divorcing them. And so they're getting rewards. The pathological parent is getting rewarded through manipulating the court and abusing, psychologically, emotionally abusing their ex-spouse because they're producing this false attachment pathology in the child. Once we introduce this approach of monitoring the child's symptoms, asking the child to stay normal range, and if the child drops to ones and twos, we're going to say his child's psychological abuse by the parent has resumed and separate the child. Now, if the pathological parent produces pathology in the child, they get less time with the child and the other parent gets rewarded. And everybody looks at the pathological parent and says, you're the abuser. Well, that's no fun anymore. That's not how the things were supposed to work. The child's attachment with pathology was supposed to get everybody else saying, that's the targeted parent's the abuser. Instead, they're calling me the abuser. And I'm not getting to see my child, and the child's going on, they're getting all the rewards. This is not working. And so the pathological parent will stop generating the attachment pathology in the child because it's no longer serving its function. That has to do with the strategic family systems intervention, where you change the power dynamics surrounding the symptom. And that's what this rating scale, this outcome measure is going to help do. It's going to take all the fun and joy of creating pathology out of the situation for the pathological parent. Now, in addition to just the outcome measure rating scale that does that, I've also come up with, as I was developing all these resources for you folks, the continued visitation schedule. This is a strategic family systems intervention that I just described, how it changes the power dynamic and things. But it looks like a behavioral intervention. So there's very criteria about if you get certain scores on the parent-child relationship rating scale, then that will trigger certain consequences, certain outcomes. And so this continued visitation schedule is a very structured way to use that reduce time and increase time to alter the family dynamic. It is possible, potentially, I could see a situation where the continued visitation schedule might be effective instead of a protective separation. Now, in all child abuse cases, we always separate the child. However, I'm a good psychotherapist, and this is a good intervention. And what it does is it sets certain criteria, because you're going to have to ask the judge to empower the family therapist to make modifications to the custody schedule based on a very specific set of criteria. So let's say the judge sets it at 50-50 for custody. And then as long as the child stays 3, 4, 5s on ratings with the verified ratings through the therapist, on ratings with the targeted parent, then that custody schedule of 50-50 stays in place. If the child's symptoms drop to ones and twos for a specified period of time, like 3 days out of 7 or something, forget what it was, but on a specified set of times, if they drop down, then that triggers the next intervention within the strategic family systems intervention, which is reducing the targeted parent's time with the child and increasing the allied parent's time with the child. Reasoning is this parent is abusing the child, creating the child's symptoms, and we need more time to fix the damaged relationship that's being caused by the pathological parenting. And so once that criteria is triggered, then the family therapist says, okay, we're now into the next set of criteria, which is we're going to reduce one parent's time, increase the other. And basically, the duration of that is when the child gets 3 successful days, then whoop, it goes back to 50-50. And so again, it's based on symptom criteria. So the child has uh, less than 4 successful days out of 7, and you say, okay, well then that's we're going to trigger the contingent visitation schedule and increase one parent's time, decrease the other. Then the child gets 3 successive days of normal range, then boop, it goes back to 50-50. Okay, so that's it, but it's an adjustment call by the family therapist based on very specific criteria, because we're going to have to ask the judge to say, you determine custody, but allow some flex based on this set of criteria. Um, and is governed by the family therapist who's kind of overseeing that. Now, to run the strategic family systems intervention, you're going to need a therapist who can do like a behavior treatment plan. Dialectic behavior therapists will have the skill set, the applied behavioral analysis, to be able to do this. Therapists and autism therapists and child development, developmental disorders, all these various therapists, school behavior problems, ADHD therapists, all could run this type of program, but none of them work in the family courts. So that's going to be your problem, is finding somebody in the family courts. I'm a consultant on any of these cases and help people develop things. I think all psychologists who working in the family court should be consulting in pairs, at least pairs. Get some consultation groups going amongst yourselves, uh, because we need to stop the fighting around the child. And that means the professionals need to stop the fighting. That's why I've been talking so much about parallel process. I educated you guys about parallel process for this specific issue, that the mental health people are caught in parallel process to the splitting dynamic of the pathology. It's called staff splitting by Marshall Linehan. Stop it. Stop splitting into all this conflict and fighting. We need to move to the center. We need to come together, and we need to recognize that all the mental health people over here are trying to get a solution to this and stop like polarizing things out. The courts do that because they want to fight about everything opposing counsel. We need to stop doing that kind of thing. And so I'll talk about various methods we can do that coming forward, like the pilot program for the family courts and various things to help facilitate that not fighting anymore. But the use of um, outcome measures is incredibly important and incredibly valuable, especially during the protective separation, especially during relapse prevention. It's going to give us a way for the child to tell us that they're being abused or that they're not, or that they're handling it without having to rat out and throw the pathological parent under the bus. We don't want to put the child in a loyalty conflict. That's a more vulnerable parent. The child's being a good kid. The child's taking care of the fragile parent. We just have to get in there and let the child know, you don't need to do that. We'll take care of that more vulnerable parent. You just stay normal, focused on your sleepovers, stay focused on your homework. Just let everything else kind of fly over your head. Um, and this is a way we can help make that clear for the child and make it clear for the court and make it clear for the parents and the therapists and everybody involved. Final thing on just this parent-child relationship rating scale um, is that we don't want to expose the child to child abuse by the pathological parent. So when I read these reports where like a custody evaluator says, the child says they really do love their targeted parent. I just go, holy cow, that child is going to face such severe retaliation when the pathological parent reads that. And so we need to be cautious about outing the child if we can't protect the child. But one of the things that this rating does is we do the collateral therapy with the pathological parent. And hopefully that's what we're going to look at as a mediating factor in the return, the restoration of contact. It's up to them to reassure us. Once they've been identified as abusive, the burden is kind of on them to reassure us that they're okay. And part of that will be participation in collateral therapy. And one of the things in the collateral therapy is that the child's just being 3, 4, 5. They're not being 6s and 7s, and you can say that, they're not being 6s and 7s. It's just normal range. It's just kind of, and with you, it's a 6. Oh, the child's so affectionate and so cooperative. And so we can bolster their self-esteem about their own parenting and allow them to diminish the targeted parents' parenting to a degree, but we just stop the degree at 3, 4, 5 and don't have to go all the way to 1s and 2s. And that gives the child some cover. If we get in the child ratings of 6s and 7s with the targeted parent and the allied parent sees that, that's going to rocket them through the roof. So that's where we just tell the child, we just need you to be normal range, 3, 4, 5. And that's true. Just 3, 4, 5, normal range. We don't want 6s and 7s for prolonged periods. Occasionally, okay. 1s and 2s, it's okay to drop to 1s and 2s for a day, 2 days. We just want to see the recovery back. That's the key issue, is that it's always about the repair. So with that, I'm going to wrap up the outcome measure series here. I recommend that this be used with all families. It's a dynamite measure: attachment networks, emotional regulation networks, and mood and arousal. And I can even go deeper into that and talk about how we want things to work with the kid, data driven. But with that, some future time. We'll talk about that later. So take care. Good luck, everybody.